This is Randy Schell, and I'm making a video cast entitled General Clinical Anesthesiology Topics Number 1. The subtitle is Toxicity and Temperature, and it's part of our anesthesiology keyword review at the University of Kentucky Department of Anesthesiology. The keywords that we'll talk about under the topic toxicity include carbon monoxide, cyanide toxicity, insecticides and anticholinesterase poisoning, nerve gases, and anticholinergic syndrome. While under the temperature keyword topics, they will be malignant hyperthermia, neuroleptic malignant syndrome, serotonin syndrome, and perioperative temperature regulation and hypothermia physiology. Let's start right in on carbon monoxide first. Normally, carbon monoxide levels are less than about 3% unless you're a smoker. 4 to 9% can occur in smokers. When we start getting up levels of carboxyhemoglobin of 15 to 20%, you can have overt signs of toxicity like headache and nausea and vomiting. And when it gets very high, you can get seizures and unconsciousness and death. Exposure to carbon monoxide can occur from incomplete combustion. You've pulled from a burning building, a furnace that's not working very well, an automobile with a closed garage door and the automobile running. In the operating room, desflurane in the presence of a dry CO2 absorber can result in carbon monoxide formation. When there's a lot of carbon monoxide around, it binds to hemoglobin very tightly, shifting the oxyhemoglobin dissociation curve to the left and decreasing oxygen content and impairing release of oxygen to the tissues. Carbon monoxide can not only bind to hemoglobin, it also can bind to myoglobin and cytochrome AA3 and cytochrome oxidases in the mitochondria. The symptoms of carbon monoxide poisoning as it develops include headache and dizziness and nausea, vomiting, disorientation, eventually seizures, shock, coma, and death. When a patient has carbon monoxide poisoning, tachypnea is usually absent. You would think that they would be ventilating very rapidly. However, remember that the carotid bodies are sensitive to P-LiLeo2, the tension of oxygen, not the content or the saturation, and they respond to low PaO2, and in the case of carbon monoxide poisoning, that is not usually low. The diagnosis of carbon monoxide poisoning is made by taking a blood gas and putting it into a co-oximeter, because the SpO2, or pulse oximeter, if you use the 2-wavelength type of pulse oximeter, which many are, it's going to continue to read quite high levels of saturation even when carboxyhemoglobin is present, because carboxyhemoglobin and oxyhemoglobin absorb at similar wavelengths. But if you take that blood gas, send it off, and have the co-oximeter separated into oxyhemoglobin and carboxyhemoglobin, and the carboxyhemoglobin should be less than about 5%, and if you have more than that present, along with a metabolic acidosis and a normal PaO2, that would be consistent with carbon monoxide poisoning. Not only do you get metabolically acidotic because the tissues are using oxygen, need oxygen, and continue to use oxygen even though it's not being delivered well to them because the oxygen content is decreased, but the tissues use the oxygen that's supplied to it, extract more oxygen from the hemoglobin that does have oxygen bound to it. And so when the hemoglobin comes back to the pulmonary circulation, there is more oxygen that's been extracted from it, and the mixed venous oxygen goes down. Let's say normal being about 70-75%, maybe it's going to be down in the 30% or 40% range, or even lower. Also, lactate can be made because of anaerobic metabolism at the tissues. How do we treat carbon monoxide poisoning? Give them oxygen, get them away from the source of the carbon monoxide, and use hyperbaric oxygen in certain situations, like when the patient's pregnant, patients who are having angina because of low oxygen content and delivery of oxygen to their heart, and those with very high carboxyhemoglobin levels. If you give supplemental oxygen to a patient with carboxyhemoglobin, you can decrease the half-time of carboxyhemoglobin from 4 to 6 hours, that is with room air, down to about an hour with 100% oxygen. If you give them 100% oxygen at 3 atmospheres in a hyperbaric chamber, you can reduce that down to about 15 to 30 minutes. Therefore, if you need to rapidly decrease the amount of carboxyhemoglobin in a patient, hyperbaric oxygen is a treatment. Cyanide toxicity is the next topic. how can you get exposed to cyanide in a clinical environment? The usual cause is nitroprusside infusions at pretty high rates, greater than 2 mics per kilo per minute. Occasionally, if you're pulled from a fire, not only can you get carbon monoxide poisoning, but also if plastic is burning and cyanide is being released, you can get cyanide toxicity. Cyanide inactivates the cytochrome oxidase, stopping oxidative phosphorylation, so we don't make energy, but the tissues need to have energy to work, so what they do is continue anaerobic metabolism, but they can't use the oxygen that's supplied to them. So what happens is the oxygen goes to the tissue can't use it, goes right back around and comes back into the pulmonary circulation with a very high mixed venous oxygen saturation. So normal mixed venous, about 70-75%, maybe it'll come back at 90 or more percent in these patients who have cyanide toxicity. So you suspect it when a patient is on nitroprusside and you're giving high doses and it seems like you have to keep going up on the dose to get the same hypotensive effect from nitroprusside, so that's tachyphylaxis. And on your blood gas, you see a metabolic acidosis and the lactate's going up, and you look at your mixed venous saturation and it's very high because the tissues are not using oxygen and the patient's confused. That would be the classic cyanide toxicity presentation. How do you treat it? Get rid of the source of the cyanide, the nitroprusside, take it away. Hyperbaric oxygen can be used in severe cases. The free cyanide molecule that's binding to cytochrome AA3 is the problem, and we need to get rid of that free cyanide ion. So the graphic on the right is showing ways to get rid of the cyanide. One way is to convert oxyhemoglobin, Fe+2, to methemoglobin with a drug called amyl nitrate or sodium nitrite. Oxidizes the hemoglobin to methemoglobin because methemoglobin can bind the free cyanide ion to cyanomethemoglobin and got rid of from your body. Another way to get rid of free cyanide ion is bind it to sulfur. So if we give sodium thiosulfate, a sulfur donor, and in our liver the rhodinase system takes that sulfur, puts it on the free cyanide molecule and forms thiocyanate, which is renally excreted. Now, if your kidneys aren't working very well, the thiocyanate can build up and cause toxicity in and of itself. So the treatment for cyanide toxicity, hyperbaric oxygen, sodium thiosulfate as a sulfur donor, amyl nitrate to convert hemoglobin to methemoglobin, which then binds the free cyanide ion, and vitamin B12, because cyanocobalamin can bind free cyanide also. And then correct your acidosis with bicarbonate. Those are the classic treatments for cyanide toxicity. The next topic is insecticides and nerve gases. Exposure can occur, for example, in a farmer who's spraying an organophosphate insecticide, or a soldier that is exposed to a nerve gas like sarin nerve gas or VX gas. The problem with these pesticides and nerve gases is that they inhibit the enzyme acetylcholinesterase. Acetylcholinesterase is in the postjunctional folds. That's where it is present, and when it's inhibited, it will not break down acetylcholine. So acetylcholine builds up, and you can get a cholinergic crisis. When you have lots of acetylcholine around, what happens? You salivate, your pupils are small, you sweat, you can urinate and defecate, nausea, vomiting, bronchospasm, and slow heart rate. And if you have massive amounts of acetylcholine present, they can get very weak, skeletal muscle weakness. And atropine, which blocks acetylcholine, anticholinergic effects, antimuscarinic effects, are utilized in the treatment of insecticide and nerve gas poisoning. So therefore the picture of atropine up at the far right as the treatment for these two. Occasionally pralidoxime in an attempt to remove the poison from the acetylcholinesterase, but this is controversial in whether it's very effective or not. Atropine is the classic treatment for insecticide and nerve gas poisoning. The next topic is central anticholinergic syndrome, and classically this would occur in a patient, often an elderly patient, who's exposed to a tertiary amine anticholinergic agent like scopolamine or atropine. tertiary amines are uncharged and can cross the blood-brain barrier, as opposed to glycopyrrolate, a quaternary amine, NH4+, which is charged and doesn't cross the blood-brain barrier and won't cause sedation or confusion or pupillary changes like scopolamine and atropine can. So if a patient has received scopolamine and atropine and develops clinical features of anticholinergic syndrome, which are shown on the far right, like mental status changes, confusion, restlessness, fidgeting, visual hallucinations, they're picking at objects in the air, slurred speech, tremor, myoclonus, coma, and occasionally seizures, but it's that classic agitation and fluctuating mental status in a patient who's also often tachycardic with a dry mouth, dry skin, and maybe even hot. That's the patient with central anticholinergic syndrome who can be treated with the drug physostigmine. Another name for it is antilirium. Physostigmine, unlike neostigmine, can cross the blood-brain barrier, and it will inhibit central acetylcholinesterase enzyme. And then, if it inhibits that, it can increase the acetylcholine in your brain and counteract the effects of it being blocked with scopolamine or atropine. Neostigmine and pridostigmine don't cross the blood-brain barrier. Therefore, physostigmine is the classic treatment for these patients who have received scopolamine and atropine, very confused, and are exhibiting symptoms of central anticholinergic syndrome. Some important points about malignant hyperthermia: genetic susceptibility, ryanodine receptor, and calcium metabolism in the muscle, along with a trigger in a patient who has the genetic susceptibility, can result in malignant hyperthermia. Inhaled volatile anesthetics and succinylcholine are the triggers for MH. Things that aren't triggers include a lot of our drugs like propofol and etomidate, midazolam and ketamine and remifentanil and other opioids and nitrous oxide and local anesthetics. But volatile anesthetics, DES, SIVO, ISO, with or without succinylcholine. Succinylcholine alone can do it. Volatile anesthetics alone can do it. Together they can do it. Cause malignant hyperthermia in a patient that's genetically susceptible. There is an association with malignant hyperthermia in patients with central core disease and something called King-Denborough syndrome. There's controversy about Duchenne's and other muscular dystrophies and its association with MH, and many will say that it is not classically associated with Duchenne's. Presentation of malignant hyperthermia: when there's lots of calcium inside the muscle and the sarcoplasmic reticulum is spewing calcium out, muscle rigidity, troponin, tropomyosins cross over each other, and the muscles are rigid, even if the patient is, quotes, paralyzed with rocuronium. So you put them to sleep with inhaled volatile anesthetic with or without succinylcholine, and you give them rocuronium at some point, and you think they're going to be paralyzed, but their muscles are very rigid. Remember that neuromuscular blocking agents act at the postjunctional membrane, while this disease is in the muscle itself. And so you can be rigid even in the presence of non-depolarizing neuromuscular blockade. The patient's carbon dioxide builds up because of the muscle hyperactivity. The temperature builds up because of muscles contracting. So CO2 and temperature goes up, and tachypnea will ensue as the CO2 builds up if the patient is not neuromuscularly relaxed. Late findings are the temperature rise and acidosis and a decreasing mixed venous oxygen, cyanosis and modeling of the skin, and hyperkalemia with peak T waves, and even breakdown of muscle and myoglobinemia or urea with brown coloring, discoloring of your urine, and dysrhythmias. But the early presentation is muscle rigidity and hypercarbia. The treatment of malignant hyperthermia is stop the inhaled anesthetic immediately, call for help. Dantrolene is the treatment. 2.5 milligrams per kilogram IV as an initial bolus, which inhibits calcium release from the sarcoplasmic reticulum, but doesn't block the reuptake of calcium. So you stop the spewing of calcium from the SR into the muscle fiber itself, but don't stop the reuptake. So calcium levels drop, rigor stops. Ryanodex is a newer formulation of dantrolene that is much easier to reconstitute. It can be done much quicker. So you treat with dantrolene up to 10 milligrams per kilogram or so. Abort or conclude the surgery as quickly as possible. Hyperventilate the patient with 100% oxygen. Cool the patient. Things like ice saline, gastric and bladder lavage. Correct their acidosis with bicarbonate. If they have hyperkalemia, you can treat the hyperkalemia with hyperventilation, insulin and glucose, and even beta agonists that are inhaled. Keep their urine output up with drugs like mannitol and keeping them hydrated. If they have cardiac dysrhythmias, procainamide is one of the classic treatments, as well as lidocaine if necessary, and arterial lines to get repetitive blood gases are useful. Note, do not use calcium channel blockers in patients with malignant hyperthermia. Well, why would you do that anyway? If they were getting dysrhythmias like atrial fibrillation, you might want to slow their ventricular rate, and a calcium channel blocker would be a classic choice, like diltiazem. The combination of calcium channel blockers and dantrolene are associated with some bad things like hyperkalemia and cardiac arrest. So avoid calcium channel blockers when you're using dantrolene. Call the MH hotline. It's a 24-hour telephone physician consult hotline when you have a patient with MH. And if you need to screen someone for MH, the classic screening technology is to get a muscle biopsy and expose that muscle to halothane and caffeine. And a muscle that is susceptible to MH will have a lot of contraction in response to the halothane and caffeine. Neuroleptic malignant syndrome, next topic. It is a form of what some people like to call slow onset MH. So it looks very much like malignant hyperthermia, which we just discussed, but it's in patients who are taking dopaminergic blockers like psychotropic drugs like Haldol and Thorazine. Acute withdrawal of Parkinson's medications can cause this. So dopamine blocking drugs, slow onset. So they get the muscle rigidity just like MH, but it's a central mediated effect rather than at the muscle itself. Mental status changes, they can get the temperature rise, acidosis, tachycardia, even muscle breakdown. Again, very similar to MH. The management is to stop those neuroleptic medications that are blocking the dopamine receptors. Dantrolene can be used not only for MH, but also for this syndrome, neuroleptic malignant syndrome. And dopamine receptor agonists like bromocriptine and amantadine occasionally can be used. Serotonin syndrome is the next keyword topic. Serotonin syndrome is a cluster of autonomic, motor, and mental status changes that occur when you have excess 5-hydroxytryptamine or serotonin in your blood. Well, what can cause you to have lots of serotonin? Pharmacologic agents, often combinations of such, like tricyclic antidepressants combined with SSRIs, or MAOIs, monoamine oxidase inhibitors, combined with other drugs like antidepressants, SSRIs, or TCAs. Some of our opiates and cough medicines and antibiotics. There's a lot of medications that, when in combination, can cause serotonin syndrome. Fentanyl, meperidine, and ondansetron are some classic ones in our armamentarium that, when combined with, for example, MAOIs, can result in serotonin syndrome. Now, mild serotonin syndrome is the patient with sweating and shivering and dilated pupils, and early on you can just give them benzodiazepines and monitor them. If it's really quite moderate levels of serotonin syndrome where their mental status starts to change, they're agitated, disoriented, they have rigidity, tachycardia, and hyperthermia that can look like MH, tremor, clonus, and hyperreflexia. You can put them in the hospital, monitor them. Cyproheptadine is a specific drug to block serotonin's effects. When it's life-threatening, they present with delirium and hypertension, hyperthermia, muscle rigidity, and tachycardia. That's the patient who's in the intensive care unit on drugs like esmolol and nitroprusside, and cooling measures are provided, paralyze them, ventilate them, and sedate them. Serotonin syndrome, usually a combination of medications that raise serotonin in the blood to very high levels, causing these symptoms that can look like MH. So if you compare these syndromes, neuroleptic malignant syndrome, serotonin syndrome, anticholinergic syndrome, and malignant hyperthermia. You realize that neuroleptic malignant syndrome is caused by antipsychotics that block dopamine receptors, and it can present like MH, but a slow onset MH. Where serotonin syndrome, usually a combination of antidepressants, opioids, antibiotics like linezolid, antiemetics like ondansetron, combine those together and you can get high levels of serotonin, and they become rigid also with dilated pupils. And anticholinergic syndrome is the patient who's received scopolamine and atropine, which crosses the blood-brain barrier and makes them very confused. And those patients, we give them physostigmine, antilirium to treat. And malignant hyperthermia is the patient that's been exposed to the trigger, inhaled volatile anesthetics, and/or succinylcholine. Their muscles are rigid, and the treatment is dantrolene. Let's move on to temperature topics. Heat loss in the operating room, the number one cause is radiation. That is, radiating heat from your body to the cold walls or cold structures within the room. So keeping the room warm is really the number one way to help keep a patient warm during surgery. Other types of heat loss can include convective heat loss, where air is blowing over you, conductive heat loss, where you're laying against something like cold steel table, or evaporative heat loss, if there's moisture or water on you, or losing heat through your ventilation and airway humidity. But radiation heat loss is number one. Rate of development of hypothermia, as your temperature drops in a surgery, oftentimes you see a pretty big drop in the very first 30 to 60 minutes. And that initial heat loss is really due to redistribution of heat from the core to the periphery. What happens is our anesthetics cause vasodilation of blood vessels like in our extremities that are usually somewhat constricted. Our hands are colder than our livers, for example. And as we redistribute blood from the core out into these arms, legs, extremities that are usually cooler, the mixing of that blood causes that first 1 to 1.5 degrees centigrade drop in the first 30 to 60 minutes in our temperature. So that's redistribution heat loss. The graphic on the far right, the big blue arrow, shows that occurring in the first 30 to 60 minutes. Then we lose heat mainly by radiation heat loss, radiant heat loss. And then our body kicks in, often at very much lower levels than normal when we're anesthetized, like 34.7 degrees classically. We will constrict, and if we're not paralyzed, we'll shiver in an attempt to save heat. And we plateau our heat loss at that point. When a patient's shivering, we can reduce shivering by giving a drug like meperidine or putting a forced air warmer on them. In fact, forced air warming is the best way to warm a patient in the operating room. Arterial blood gases are affected by temperature, and we correct them for a patient's temperature. For example, if you draw blood gas from a patient whose temperature is 32 degrees, you put it in a blood gas machine. The blood gas machine actually warms it to 37 degrees and spits out the numbers at 37 degrees. But you need to correct it for the patient's real temperature. And if it was 32 degrees, they're cold. Hypothermia decreases the kinetic energy of the molecules of oxygen and CO2, and the partial pressures are lower. So when you correct for being cold, it will drop the PaO2, drop the PaCO2, and if the PaCO2 drops, that looks like a respiratory alkalosis, and your pH will go up, more alkalotic. That's the effect of hypothermia on your blood gas. Mechanisms of heat conservation include two things, vasoconstriction being one of the main ones, and that's impaired when you're under general anesthesia with our inhaled volatile anesthetics like DES and SIVO and ISO. And it's also impaired by spinal anesthesia and epidural anesthesia, and that's what the pictures on the far right, the graphics, are showing the effects of desflurane on shivering in green, on constriction of blood vessels in red, and on sweating in the blue. And you can see that desflurane very much impairs the threshold for vascular constriction and sweating. And you can see that L-fentanyl, not so much, dexmedetomidine, some, and propofol quite a bit. So our anesthetics impair vasoconstriction. And shivering, if you have a patient anesthetized and paralyzed, obviously they're not going to shiver, and so they would lose that mechanism of heat conservation. Preventing and treatment of hypothermia, keep the room warm. It will decrease radiant heat loss. And forced air warmers, blowing air through the forced air warmer, is the most effective method to warm a patient. Not a warming mattress, not a humidivent, not trying to warm your IV fluids. That's not very effective, but forced air warming is effective at warming a patient. Physiologic and pathophysiologic effects of moderate hypothermia. When a patient's cold, their oxygen consumption goes down and their CO2 production goes down. Blood flow to their head goes down because cerebral metabolism is decreased. And metabolism of some of our drugs can be messed up because the enzymes in the liver aren't working so good. The kidney often undergoes a cold diuresis. We start to make more urine as we're cold, partly because the enzymes that are involved in the kidney tubules don't work as well, and sodium water excretion from the kidney goes up, cold diuresis. And as you're cold, your vascular resistance increases. You're vasoconstricted. So blood pressure often goes up, and as blood pressure goes up, heart rate can go down. So cold causes vasoconstriction and bradycardia, a stress response with high levels of norepinephrine, which can then result in ventricular ectopy and dysrhythmia. So a cold patient can have a lot of ventricular premature beats. There's some complications of mild hypothermia that are important. When you're even just a little bit cold in an operation, your platelets don't adhere as well, and the enzymes involved in your coagulation system don't work as well. Therefore, blood loss can be greater. Immunity and white blood cell chemotaxis is not as good, so wound infections can be increased by mild hypothermia. Your sympathetic nervous system kicks in when you're cold, and norepinephrine levels go up, and hypertension and tachycardia and shivering can occur. And when hypertension and tachycardia and shivering and increased oxygen use with shivering occurs, if someone has coronary artery disease, that's a pretty bad thing, and myocardial events like myocardial ischemia can ensue. This ends our miscellaneous clinical topics, number 1 in our keyword review. I hope you have a great day.